You can have major depression, a persistent depressive disorder, adjustment bipolar 1 or 2. It could be psychothymic. It could be PMDD, substance-induced, postpartum. So there are different reasons that can cause the onset of a mood disorder. So it's believed that it could be alterations in neurotransmitters. It could be genetic, such as having a first-degree relative who then puts you at risk. Your mother has depression, much like anxiety. It can be familial. It could be cognitive issues, learned helplessness. It could be a characteristic of your personality. It could be life events and stress. So many people with a depressive disorder go undiagnosed, secondary to not wanting to be labeled. Like sometimes I can think of one friend that I talk to very regularly, and she has an anxiety disorder. And I have pointed out the symptomology to her and identified it as such. And she refuses to get help because she works in the medical field and she doesn't want to be labeled. She doesn't want to have a diagnosis. She doesn't want anyone to look at her file and say, I have anxiety. So I'm sure it's the same for depression or any other mental illness. So can you imagine if a patient has like a mood disorder that plays into like a bipolar or schizophrenia disorder? They probably will try to avert treatment because of not wanting to be labeled. So mood disorders affect a huge amount of the population. It said here 20 to 25%. It is diagnosed twice as much in women than it is in men. It usually begins earlier than once thought. And as I interact with children, and I'm treating 7, 8-year-olds, 10-year-olds, and they're like, I'm so depressed. And you're like, what changed in society? Like, I didn't even know these words when I was a child, and now it's commonplace. And this is why we have to educate our children, because they're a lot more knowledgeable than we were. Nearly 2 out of 3 patients with one depressive episode. So if historically you went through a depressive episode, it is said here that within 10 years, you will have a reoccurrence. So it's usually not just solitary, it usually happens later on at a different time. The severity of the first episode predict the persistence of it reoccurring, or to what degree it will reoccur. So how do we know if a patient is depressed? They could present with a depressed mood, sadness, or anhedonia. Anhedonia is the inability to experience pleasure. They need to have at least 5 symptoms for at least 2 weeks. And these symptoms could be irritability, anger, rage, hopelessness. And hopelessness, as we know, is the most important factor to determine one's risk for suicidality. They can have symptoms of worthlessness, like, why am I even here? There's no point in living. What am I living for? Nobody cares about me. They can have difficulties with concentration, difficulties with focus. And this is why I ask all my patients, not just my patients who have ADHD, about their focus and concentration. Because focus and concentration can play heavily into depressive disorders. They have difficulties making decisions. They can even feel some kind of guilt. They can have psychomotor retardation or agitation. So either they're slowed down or their motors are speed up. They can have changes in their eating pattern, eating and sleeping, either hypersomnia, insomnia, or an increased or decreased appetite. Their energy level is called anergia, lack of energy, just feeling tired and drained. And I just spent the entire weekend in bed. I just feel like I couldn't move, because physically it can manifest itself as well. They have fatigue. They start isolating from family, friends, social interactions. How many times have you invited John to a party and he tells you he has to work, or he's busy, or he'd rather stay home? Isolating. These signs and symptoms often impact the patient's usual functioning. There's often a preoccupation with death. They can have suicidal ideations or plans or even attempts. So the patient needs to have 5 or more symptoms of depression, including either a depressed mood or anhedonia for at least 2 weeks to have a diagnosis. And of course, it cannot be as a result of a psychological effect of a substance use or a medical condition. This is the patient who you will not just let this patient stay in their room because Mr. Jones is depressed and it makes for an easy shift because he's just gonna sit in his bed or lay in his bed all day. No, this is the patient you wanna make sure you go down to this patient's room, assist them with their ADLs, assist with feeding, try to get them up, try to engage them as much as they will tolerate. Dysthymia. This is a patient who has a persistent depressive disorder. Their symptoms are similar to those of depression, but they never reach the same intensity. So it's not a major depressive patient, but they still have similar symptoms. They will have 2 or more of the depressive symptoms and moods for more days than not. They often have fatigue, low energy, low self-esteem. So this is depression, but not on the full-blown major depressive state. They are never without signs or symptoms for more than 2 months at a time. And it's not due to any medical or substance use. They must have a low level of depression for at least 2 years to be diagnosed, 1 year for children under 18. They will often say, I feel like I'm in the dumps. This is just me. I've always been like this. So this patient is probably still going to work, still interacting, still getting out of the house and doing things. They just have this low level depression. Dysthymia. Now, very often things can happen in someone's life where it could be divorce, it could be change in status, they could have moved to the US from a different country. Like lots of different things can happen. And in facing that change, some patients have a hard time adjusting. And when a patient has a hard time adjusting, they can be labeled as having an adjustment disorder. This is an emotional or behavioral symptom in response to an identifiable stressor. So this patient is usually able to say, I started feeling this when I moved to Connecticut from Florida. And these are things I hear all the time, or after I got my divorce, or after my son died, like lots of different reasons. They can also usually often tell you why they're having these issues. The marked distress is usually in excess of what is to be expected. So while it's not easy adjusting post the death of a child, if your child died 10 years ago and you're still struggling with function and stuff, then you're having some issues with adjustment. Usually cause impairment in functioning. Once a stressor has terminated, the symptoms do not persist for more than an additional 6 months. So this could be further labeled as having an adjustment disorder with a depressed mood, an adjustment disorder. It could be present with anxiety. They could have an adjustment disorder with mixed anxiety and depression, or an adjustment disorder with a disturbance in their conduct, which means their behaviors. Like, say, a child in foster care goes to a new home and they're just not liking this new family, this new setting. They could have so they start acting out, breaking things, running away. So that would be an adjustment disorder with disturbance in conduct, their behaviors. It could be an adjustment disorder with mixed disturbance of mood and conduct. Maybe they're depressed as well as, or feeling anxious as well as acting out. Or it could be an adjustment disorder unspecified, like we can't say exactly if the patient is anxious, depressed, or having any mood symptoms that we know they're having issues adjusting to the stressor. Any questions so far? Okay. Bipolar 1. This is characterized by one or more manic episodes, depressive episodes, and mood swings. The patient may also have hypomania, mixed or major depressive episodes. Bipolar disorder causes clinically significant distress or significant impairment in functioning. Mood swings can last for weeks or months. They cycle back and forth from manic to depressive to baseline, manic to depressive to baseline. The cycles, they vary in duration, so it's often helpful to help the patient determine what their pattern is. Like, hopefully you can help them determine when they start decompensating. Sometimes it can be a certain time of year or around the anniversary of someone's death or something. Usually, sometimes they can help to identify what's precipitating the change in their moods. While bipolar 2 is characterized by one or more depressive episodes with at least one hypomanic episodes. So again, bipolar 1, they will have one or more manic episodes. Bipolar 2, they will have at least one hypomanic episode, which means not full-blown mania, which means not the psychotic symptoms, but probably the increased speech, the irritability, the sleeplessness. So that's the hallmark difference between the two. This patient with a bipolar 2 disorder will have depressive episodes that last at least 2 weeks. Their hypomanic episodes last usually around 4 days. They've never had a manic or mixed episode. Signs and symptoms, it also causes them clinically significant distress in school, in their occupation, in all areas of their daily function. They will have these difficult times. Does anyone have any close relation to anyone who has a bipolar disorder? Friend, family member, patient? Your grandma? And some people with a bipolar disorder, okay, it is also like schizophrenia. I was surprised to learn that it's very, very common to find patients with a bipolar disorder. When people hear bipolar and they start thinking of mood swings. And while it could be like manic depressive moods, it's not like mood swings. It's usually more cyclic. Symptoms of mania. How do we know when a patient is manic? They can have a distinct period of abnormally and persistently elevated expansive or irritable mood lasting at least 1 week every day for most of the day. So every day for most of the day, they're irritable, this abnormal, elevated, expansive mood. Inflated self-esteem or grandiosity. Decreased need for sleep, feeling rested with after 3 hours of sleep. So they're telling you, oh, I'm barely sleeping. I stay awake all night and I'm planning for this business I'm going to start. Oh, when do you sleep? Oh, I don't need to sleep. I get an hour or two here and there. And aren't you tired? Oh, no, I'm not tired during the day. And they go on like this for quite a period. They're more talkative than usual. They usually have pressured speech, flight of ideas. So they're jumping from one subject area to the next, or even racing thoughts. Increased distractibility. They can even become more social. This is the person who never used to go to parties or hang out, and all of a sudden she's out late out here, or she's out late at nights, hanging out, partying, meeting new people, dating. Like, what is going on here? Symptoms of mania. It can be very witty, and sometimes the patients who themselves is in this state of mania can recognize their increased witty state, and they will like this state. They will often tell me, hey, this is when I'm at my best. I'm out there doing things, getting all my ideas going, and you listen to them, you need some help before you crash. They can be intrusive, interruptive, even disruptive, because they're not able to use social cues or reason well because they're in this manic state. They usually have increased goal-directed activity. So whether that goal-directed activity is, oh, I have to find a job, I have to start a new business, build a house, whatever their goal-directed activity is, they're usually working on something and they're very driven to complete it. They can have psychomotor agitation. It's that restlessness. They start to involve themselves in excessive, high-risk, pleasurable activities. So they could be going out, meeting a new guy every night, having sex with them. Like, this is not who I know this person to be, but this is behaviors that can happen while they're manic. They can have marked impairment in social or occupational functioning. They may have psychotic features such as hallucinations, and they may require hospitalizations because while they're hospitalized, they will be given what kind of medications? What group of medications would they be given if they're in a manic state? So remember, they can have psychotic features, they're agitated, they have psychomotor agitation, they're restless. So it could be benzos. They could get SSRIs if they're feeling anxious or depressed, but what's the big one? Mood stabilizers or even some low dose antipsychotic. Because remember, we're talking about mania. Schizophrenics also have mania. Remember those things? Like those psychotic symptoms. Not that they have a manic state, but it can also have these hallucinations and delusions, which is what you would treat with the antipsychotic. But mood stabilizers are the #1 class of drugs for mood disorders. So what separates mania from hypomania? Hypomania is similar to mania, but it never reaches the same severity or duration. So while this could be going on for a while in the manic state, hypomania usually is like 2, 3, 4 days. And the patient will have at least 3 of the following: decreased sleep, increased grandiosity, more talkative, easily distracted, flight of ideas, increase in risky behaviors or increase in goal-directed behaviors. To be like fun to be around, humorous. They usually make good company, and sometimes it's argued like artists and people who are out there in the public who are very high strung and stuff. They may have just a little bit of something, but who knows? Because they're usually like very smart, witty people. They will see a change in their usual functioning, but not impairment. So they will be able to go to work, get work done, function as they would, but just like in a heightened state. However, they're not in control of their moods, so they probably snapped at the boss, yelled at a coworker, and they will have not had a marked impairment in their function. So what's a mixed episode? The criteria is met for both manic episode and major depressive episodes. The patient is having mania and depression nearly every day for at least 1 week. And these moods alternate rapidly. It causes the patient impairment in functioning and may have some psychotic features, and that's the hallucinations and the delusions. That's a mixed episode. Are you able to know these, like what is bipolar 1, bipolar 2 mixed? It's a lot of stuff to know, and as I say, as we tease through the material more, I will try to point out some stuff that you need to be more mindful of. Psychothymic disorders, as the name states, psychothymic. So we try to expose you to this information so as you interact with your patients, you encounter patients and they start giving you symptomology, you can then draw on the knowledge that you have, the information you have learned to better able to assist these patients or understand what is being presented. Psychothymic disorders last at least 2 years. The patient can have numerous periods with hypomanic symptoms, cycling with some depression. So I'm hypomanic, then I'm depressed, then I'm hypomanic. The signs and symptoms only for 1 year if a child or adolescent is under age 18 for diagnosis. They never meet criteria for a major depressive disorder, and they are never without symptoms for more than 2 months during the 2 years. So this patient will have some hypomanic and some depressive symptoms, but it's not major depression, it's just some low-level depression, and it's not full mania, it's some hypomanic behaviors. It'll cause them clinical significant distress in their functioning. They will have no major depressive, manic, or mixed episode during these 2 years. And some patients will stay in that state for a very long time, and that's your cyclothymic disorder. PMDD, Pre-Menstrual Dysmorphic Disorder. I have a few patients who can identify this themselves. They tell me, I definitely get more irritable, anger, or find that my moods are a little bit more unstable around my period. They will also say they have a depressive mood, feeling hopeless, and feeling anxious, not as interested in their usual activities. So that plays into the depressive mood. Difficulties concentrating, they're having energy or lack of energy, feeling lethargic, tired, appetite changes, hyper or insomnia, or just feeling overwhelmed. So this is just a rough period for this person who is having these disorders. I had one mother who came to me who insisted that her teenage daughter had PMDD. So I gave them a table and track her moods and behaviors over a 3-month period. And then when she came back, it turned out it wasn't. This was the child's baseline behavior throughout the month as well. So we were able to tease that out and realize that it was, in fact, a depressive disorder that this child was experiencing. So sometimes patients could have a mood disorder, which is due to general medical conditions. It can be prominent or persistent. And this mood is characterized by being depressed or having lack of interest in most, if not all, activities. Or they could have an elevated, expansive, or irritable mood. And there is evidence that their disturbance is linked specifically to their general medical condition. And of course, it will cause them clinical significant distress. Like, what are some general medical conditions that you think could lead to a patient having a mood disorder? Cancer. Yes, and the several treatment that's around. Or say they got into a serious car accident, broken limbs, and they're laid up at home or in a hospital and they can't work and they can't provide for their family. So there are lots of different things can play to what conditions can play into patients having those mood disorders. Then we have the substance-induced mood disorder. This is a prominent or persistent disturbance in the mood characterized by one or more of the following. This patient can be depressed. The noise level outside is crazy. This patient can be depressed or have marked diminished interest or pleasure in all or most activities. They can have an elevated or expansive or irritable mood as well. And there will be evidence that the symptoms have developed during or within a month of the substance intoxication or withdrawal. So sometimes I'll have patients come to me, and it's usually young adults, and very often it's after they start smoking weed, and since I start, I'm feeling anxious, I'm feeling depressed. And when you do the timeline as to when the symptoms started, you can correlate it to the substance use, and you realize, when I went back to school, I wasn't using, but then when I came back for the summer, I started using again, and you can see how the moods change with the use. And if it is tied with the use, then they can develop a substance mood disorders. And you try to educate them to stay away from the stuff. Some patients also get depressed around peripartum. They will meet criteria for having a major depressive disorder with the signs and symptoms appearing during pregnancy or within 4 weeks after delivery. So they will meet the major depressive disorder criteria, but it develops either during pregnancy or within 4 weeks after delivery. Symptoms must last at least 2 weeks. It's different from just the little baby blues that we're used to new mothers having. So it's not the baby blues. This is more intense. Pretty prevalent. Some patients may also experience psych episodes and get command hallucinations, delusions. And if we look back in history, I'm sure you can remember some news story somewhere where some mother either killed her infant or drowned her kids or after birth or something. But they can have these command hallucinations, and that's why it is very, very important that we assess for these things and seek to treat the patients effectively. If a patient has a depressive disorder after their first pregnancy, they have an increased risk for subsequent pregnancies as well. How do we treat these mood disorders? With therapy, CBT, talk therapy. So therapy is very important with medications, and we know this is the SSRI group. It could be deep brain stimulation, or say this patient has not been responding to therapy. It could be ECT, electroconvulsive therapy. We looked at that in our first class, those non-pharmacological approaches. Pharmacology. We looked at SSRIs, MAOIs, Wellbutrin, which is the bupropion, as well as tricyclic antidepressants. We had gone through this list when we looked at the first class where we looked at non-pharmacological treatments. So these are all different classes of drugs that are used to treat depressive disorders. As it relates to bipolar specifically, bipolar is treated with mood stabilizers, and that will be lithium, lamictal. I don't see Latuda here, but that's another one that's used, Depakote, Tegritol. So these are medications that are used to stabilize their moods. We have to remember that we educate patients about the advantages. Okay, it's going to help to stabilize your mood, but there are also disadvantages to using these drugs. You'll have to use it lifelong, more than likely. So you want to educate them that not because you start feeling better means you're going to stop taking the drug. They come with side effects. They interact with a lot of different drugs. You want to teach them to avoid different activities, like activities that, especially if they're on lithium, avoid activities that cause a lot of heavy sweating. You want to educate patients that if they're taking lithium, they need very frequent blood levels. And the heavy sweating, the patient has an increased risk of side effects from lithium if the patient is dehydrated or have excessive sweating. So you want to educate them, hydrate, stay out of the sun. Lithium specifically, that's like the gold standard treatment for bipolar disorder. So you think bipolar, you think lithium. Patients have to do these blood draws. I do them like when they just start, like every month for the first couple of months, then they go to like every 3 months standard. The therapeutic range for lithium, which it's very important for you to know, is 0.6 to 1.2. It's toxic if it's over 1.5. I just had a patient the other day who came for her blood draw and her lithium level was 2.0. She was sent to the emergency room immediately, only to find out she came and had her blood drawn after she had taken her lithium that morning, which we usually tell the patients, come 12 hours after your last dose, hold the morning dose until after the blood draw. So she had actually taken lithium that morning. But it's very important that if a patient comes on the unit, they're having lethargy, seizures and stuff, they're taking lithium, you want to make sure their lithium level is within range. So you can rule that out. Diarrhea, vomiting are all side effects of lithium toxicity. Very important for you to know those as well. Lamictal is another mood stabilizer. I educate my patients when they're taking it. Usually in the first couple of days, they can get a rash. It's a life-threatening rash, usually appears on the chest first. If I educate them that if you notice you have a rash, stop the meds. And I am yet to have a patient who has developed a rash from Lamictal. I prescribe it quite a bit, and it's very effective. It's not as harsh as lithium. So patients, because as we know, lithium is excreted through the kidneys, and I have a lot of patients, especially my older patients who have taken lithium over the years, end up with a lot of damage to what body organ? The kidney. So I try not to use it first, but it does work. It's old school and it definitely does work. Other side effects of Lamictal could be flu-like symptoms, dizziness, blurred vision, and headaches. We have Depakote, which is also very widely prescribed, like lithium, patients who take Depakote need a therapeutic range drawn. The range is between 50 and 100 micrograms per ml. And I do it at the same interval I do with lithium. So have them come in, check their Depakote level as they would their lithium with the same parameters in place, fast and blood work 12 hours after after the last dose. So CBC, liver function test, because it can damage their pancreas. Toxicity may begin. The patient has facial swelling, fever, GI upset, hair loss. That is a common complaint I get about my patients who are Depakote. It's hair loss. And then we seek to take them off the drug and try something else. We have Tegritol. It's an anticonvulsant, but it's also used to treat mood disorders. Also check for those blood levels as well. It can increase the patient's liver enzymes. So you want to make sure you're educating patients about safe use. Like sometimes I have patients tell me, oh, I was feeling kind of up, so I took 3 extra pills. So you want to just educate them about the side effects of these drugs and to take as prescribed and follow treatment recommendations. The Tegritol is used particularly in rapid cycling bipolar 1 disorders. And it's unbelievable, but we've come to the end of the material. So there is something I usually do, and it's called Kahoot. And it's an online game where I put different you need to know them like in depth. Surely, yes, you need to be able to differentiate the difference between the two. But as we go through, I tell you, I will give you a list of the things you should focus on.